this on a case, I guess, and we'll just go through question and answer. It'll be interactive, okay? So how do you write on this thing?
There's a white pen.
This thing?
Yep. And you can just use any of the erasers to erase.
All right, so this is kind of off the cuff, so we'll just go through a case of, let's say, a 60-year-old female comes in with right lower quadrant pain, okay? She gets a CAT scan, it shows perforated appendicitis. She goes to the OR pretty sick to begin with. Let's say she has a temp of 100.2, heart rate of 103, respiratory rate of 16, and a blood pressure of, let's say, 96 over 54. Her lab show a white count of 16, and CT shows perf to appy, okay? So this could be a woman with pneumonia, this could be a woman with a UTI. With this, what types of tests would you order on her? Labs.
Lactic.
Yep, the lactic acid. In addition to the other types of things, let's say we have also a chemistry which shows she has a creatinine of 2.0, which is new, so she has some renal failure. Rest of electrolytes are okay. Anything else? So lactic acid, do you guys know why he wants to order a lactic? No? Okay.
To see if she's septic.
Correct, exactly. So sepsis, right? So do you guys know what the definition of sepsis is?
Yeah, there's like
Oh, Emily, we just went over this.
Huh?
Would be SIRS criteria.
Yep. And what are SIRS criteria?
So we would need a respiratory rate that's above.
You can just tell me what the criteria.
Respiratory rate, increased heart rate,
Okay.
weight count, and a hypertensive blood pressure.
Nope. Anybody? Huh?
Fever.
Fever. Yes, temperature. So, respiratory rate, I think it's over 16, heart rate over 90, white count over 12, or a white count less than 4. Which one's worse for a patient in terms of they're coming in sick and septic? Is it a worse prognosis if they have an elevated white count or a low white count? Low white count, right? It's a very poor prognosis. And temp, a temperature, I think 100.2 or higher, or hypothermia. Some patients, again, just like a low white count, a low temperature in a patient who's septic is a bad sign for them, okay? So 2 out of 4 of these would qualify for SIRS criteria. Are you guys familiar with SIRS criteria? So 2 out of 4. Now, like if I ran up the stairs to get here, I'd probably have SIRS criteria, right? I'd have a respiratory rate of 20 and a heart rate in the 100. So it's very non-specific, right? So, but when you attach it to infection, how do you get rid of it?
Yep, take the eraser.
This?
Yep,
Oh, cool. Wow, this is fancy.
just for you.
You fancy. Infection or suspected infection plus SIRS criteria, right? 2 out of 4 of these is positive SIRS equals sepsis. Now this is the old definition of sepsis, okay? There's a newer definition of sepsis, but we still use this across the nation because it's easier. It's a great screening tool, right? So this lady has sepsis from ruptured appendicitis, okay? Do we know what the definition of severe sepsis is?
Get it, Emily. You got it.
Sepsis plus proof of end organ damage.
Right. So what types of organs can fail?
Your liver, your lungs can start failing, kidneys.
What's the most common organ to fail?
Kidneys.
Kidneys, right. They're very sensitive. So sepsis plus end organ failure. Right? Other things, mental status changes, right? That's a big one. That's a very poor prognosis too if you have a patient with sepsis and their end organ that's being affected is their brain if they're altered, right? They're confused, they're agitated. Liver sometimes, if you see a coagulopathy like DIC, That's organ failure of the hematological system. So that's that, and then septic shock is what?
Associated with hypotension and port perfusion, so like decreased cap refill.
So when we talk about in this scope of defining sepsis, severe sepsis, septic shock, it's basically low blood pressure with sepsis. Okay?
Hypotension and hypotension refractory to fluids.
Hypotension refractory to fluids. It is. The newer definition is hypotension refractory to fluids with a lactate greater than 2. The old definition, which we still use, is just hypotension if you don't respond, meaning the blood pressure does not respond to IV fluids.
The lactate of 4 is somewhere there, right?
Yeah, I think the new definition actually is the lactate greater than 4 is you need a lactate greater than 4 for septic shock.
So
Not for the old definition, not for sepsis 2.
If you have a lactate of 4 but no hypotension, you're still septic shock.
We'll talk about that. Yep. So we'll get to the lactate in a second. So we have sepsis, right? You have end organ dysfunction, that becomes septic, severe sepsis. And if you have hypotension despite fluids, you have septic shock. So let's say before they go to the OR, the blood pressure drops to 80/40 in front of your face, right? What would you do?
Give fluids.
Fluids. How much fluid would you give?
2 liters.
30 mLs per 100
Yeah.
per
You-
100 mLs.
You're almost there.
Yeah.
30 cc's per kilogram,
Per
right? So let's say, and that's of ideal body weight. You guys know what ideal body weight is? What's ideal body weight based on?
Height and weight.
Height,
Height
And BMI.
no,
Gender?
right.
Yeah.
Height and sex are the, so the tall, it really is based on height and sex. So the taller the person is, the larger their ideal body weight is. So it is 30 cc's per kilogram of crystalloid, of ideal body weight, okay? So let's say the ideal body weight is, 70 kilograms, which most people are, it'll be 2,100, right? 2 liters of fluids, like Greg said. So usually you're safe between 2 to 3 liters of fluids. You don't want to really, so you give the 2 to 3 liters of ideal body, what type of fluid are you going to give?
Crystalloids.
Crystalloid. What type of crystalloid? What are the types of crystalloid out there? The main ones we use in the hospital.
LR.
Yeah.
NS.
Right. So those are the main ones. LR, NS. Which one should we use? LR. Right. So there's a couple studies that came out a couple years ago, especially in the setting of critical care, but we really should be using it in the hospital for general IV fluids, and the surgeons are good about that. The medicine team is not. Is LR. 2 to 3 liters of LR. Okay. So you give them that, and we'll come back to that. Okay.
If you need another page, you can just hit the plus
Oh, okay.
when you're ready.
Okay, awesome. So does that make sense up to this point, right? So give fluids first. Lactic acid, so what does lactic acid tell us?
Perfusion status.
Yeah, it gives us, there's a lot of debate on the what it actually is telling us, but for generality, it tells us if your end organs are being perfused. If they're not, because the thing our organs need to function is oxygen, right? And blood pressure brings that oxygen to the end organs. If they're not getting enough oxygen, they create anaerobic metabolism, which is lactic acid, right? So lactic acid greater than 2 is considered abnormal. What are things that can cause a false positive lactic acid?
vomiting.
Liver failure can do it. Vomiting, not necessarily.
Dehydration.
So I should put this another way. So any type of shock can cause lactic acid. So if you're in hemorrhagic shock, you're bleeding out, that's your end organs aren't going to get blood, your lactate's going to be up. Septic shock, anaphylaxis, your blood pressure is low, your end organs aren't. This is more of a case of your lactate is up, but it's kind of at lab, like it's the patient's lactate's really not up. It's when you're really having a tough time drawing blood, and they tourniquet your wrist, and you get a local lactate, so you're just seeing local ischemia in that area, so that can falsely elevate the lactate. So we see that in the hospital several times a month actually, and you just repeat it from a better stick or something and it's better.
Really? Just
Yeah.
even tourniquet will?
Yeah, sometimes.
Drive it
Yeah,
up?
it's a very, so if you find that the IV nurse has a tough time getting it, just, you know,
All right.
because sometimes it doesn't make sense. The patient has a lactate of 6, but they look fine too, you know, and you go back and see, oh yeah, they had trouble drawing blood from you, doctor.
Do the nurses draw on the unit, or does IV therapy?
Some of the nurses do, but IV therapy does too sometimes. Yeah. So lactate of greater than 2, and whoever said who said liver? Joe. So liver failure. Your liver is what consumes lactate. So if your liver's not acting right, your lactate's going to go up. But that's just a function of liver dysfunction. It doesn't necessarily mean that patient is that sick.
Do the dialysis patients not clear as well, or?
No, they do. Yeah. It's more the cirrhotics and liver guys. So that's another sign that you're having end organ dysfunction, right? So a lactate comes back at 2. That's a red alarm. Lactate greater than 4 is equivalent to septic shock. Okay, even though their blood pressure is 110 over 70, their blood pressure is fine, but the lactate is greater than 4. That's defined as septic shock. Okay, because end organs, for some reason or another, aren't getting oxygen. And that makes sense because some patients live at a blood pressure of 160 over 80. They don't take their antihypertensives, and a blood pressure of 110 for them is low, even though we think of that as normal, right? That's relative hypotension. Does that make sense?
Mm-hmm.
So, how do you switch this out?
You can push the plus
The
sign
middle, the
in the
plus
middle,
sign.
I think it'll give you another
Okay,
screen.
great.
There you go.
So we give the patient 2 liters of fluid, right? 2 liters of LR, and their systolic blood pressure comes back at 85 still, right? We know from old charts that blood pressure usually runs around 110. What do we do then? Yeah, so you, again, reassess the patient. So if you look at the patient, you've given them 30 cc's per kilogram of IV crystalloid, but they say, I've been vomiting for 3 days, I haven't eaten anything. You may want to be more generous with the fluids. You may want to give them another couple liters, but they say, I just got sick today, I've been eating fine. They're not going to be clinically dehydrated, right? So you gave them fluids, that should be enough. You start them on vasopressors. And what would you start them on? Levophed, right. So Levophed is a good choice for basically any type of shock. Even congestive heart failure or cardiogenic shock, the choice is not dopamine, but it's Levophed, okay? And studies have shown that. And Levophed, you can go into your orders, and if you type in Levophed, it'll come up in terms of how you titrate that. And what do you want to titrate the Levophed to? What blood pressure or what MAP?
Greater than 65.
Yeah. Right? Levophed was told of MAP of 65 or higher. Right? And if you're escalating on a dose of Levophed, we'd call low dose Levophed maybe 5 to 10. 10 to 20 is medium dose. 20 to 30 is high dose. Okay, if you really find that you're really cranking up on the Levophed, you should get an arterial line, and anesthesia puts those in here for better blood pressure monitoring because your non-invasives aren't going to do as well. The other thing is you need a central line for Levophed. Doesn't have to be put in right. If the patient's hypotensive, you need to get something in. You can start it peripherally, make sure it's a good peripheral IV that's stable, because what happens if it isn't? Yeah, it could leak out, right? And then it can cause basically skin necrosis, okay? If that ever happens, just call pharmacy and they can treat with phentolamine, it's called, okay? But make sure it's a good IV you're giving peripheral while you're waiting to get the central line in. Any questions about that?
Is the phentolamine, is that IV also or is that IM?
That's subcutaneous.
You could just inject it locally?
Yeah.
And then who injects that? Is it
That's a good question.
the
I don't know.
clinician or
I think nurses have done
do the
that.
nurses do?
Yeah, I think the nurses have done it because it's like a sub-Q.
Okay.
I'll have to ask the ICU nurses. I've never done it. I've ordered it. What's the one thing with Levofed? Because Levofed is what's the one problem with Levofed sometimes that you can have? This is kind of what am I thinking? So let's say this patient is systolic blood 185. They have a history of AFib, and now they're in rapid AFib in the 130s.
When you get tachycardia.
Yeah, so Levofed can tickle the heart sometimes. So in AFib, rapid AFib or extreme tachycardia, which I would say is greater than 120 to 130, you may want to use something called miacinephrine. Anesthesiologists like this pressor instead. Okay, not a bad thing. You can actually have a lot more room to use this peripherally, miacinephrine. It doesn't cause as much skin necrosis. So if you're running into tachycardia with Levofed, you could switch to miacinephrine. Okay.
So if they have tachycardia, and say you're on like 20 Levofed, would you add the Levofed and go to Neo, or would you just drop the Levofed down and then put them on a little bit of Neo or vasopressin?
So what I would probably do is I would add vasopressin
Okay.
to the Levofed.
Try to titrate down the Levofed?
Yeah, yeah. If it's like 160s rapid AFib, I just say let's not screw around. Let's just switch to miacinephrine. You can add vasopressin
Stop
too.
completely the Levofed.
Yeah. Well, they'll titrate it. Yeah. So he
And
does.
then, like, irrespective of tachycardia, just you're on Levofed and you're still hypotensive. Like, are you waiting till you're at
No,
30 max before you add the vasopressin, or what?
no. I add it between 10 and 20.
Okay.
Yeah. So vasopressin is a unique vasopressor. I think it's around 0.4 units per minute. So you don't titrate it, you just add it, okay? And you can add it to either of these when you get to medium doses of vasopressors. It's shown in studies to not necessarily help mortality, but it helps you reduce doses of Levofed if you need be, okay?
And what's your dose that you're comfortable doing peripherally with the Neo?
Up to 300. Oh, you're saying peripherally? I think like 150.
Okay.
Yeah, I would still try to get a line in these patients. It still can cause problems. Okay, but you have a lot more wiggle room, if it's a busy night or something like that. So we got them. We're managing them hemodynamically. What's the most important thing beyond all this that the patient should have received very quickly? Antibiotics, right? So that should be step 0. Antibiotics. So every hour that you delay, every half an hour you delay of antibiotics in a severe sepsis septic shock patient, their mortality increases by like 8%, right? So if you have a pretty sick patient, this is not for general infection in the hospital, but for pretty sick septic patients, or even make sure you tell the nurse we need these antibiotics in stat, okay? Because there's nothing more important than getting the antibiotics in fast as possible, okay? And sometimes if you can't get IV access, give them a shot of IM ceftriaxone, okay? That we run into that once or twice a year where we're waiting for access, it's busy, or give them an oral antibiotic, Augmentin or something. Really important. Can't emphasize that enough. All right, so you got antibiotics in, you checked your lactate. Obviously, you check blood cultures, right? In any sick patient, check their blood cultures. Lactate, blood cultures, antibiotics. You resuscitated them in fluid, decided if they're dehydrated on top of that, if they needed more fluids or not. If not, we started them on vasopressors. And the most important thing is source control. You've stabilized them enough to go up to the OR, and they'll go get their appendix out, right? Any questions about sepsis or septic shock? No. These guys have heard this lecture like 8 billion times. So they come back. 20 more minutes. Let's get out of here. From the OR on the ventilator. sick, we wanna leave them on the ventilator, we may take them back to the OR tomorrow. What are the parameters on a ventilator that we're changing? So, how much is the ventilator gonna breathe for them, respiratory rate, okay? Tidal volume, what's the volume that the ventilator is gonna give them, which each rate, each breath?
Peak?
Peak. And yeah. So 4 parameters, right? So just think of it, like when we breathe, we have a respiratory rate. How much volume are we gonna take with that respiratory rate? How much oxygen are we breathing? And PEEP is kind of a unique thing. So respiratory rate, what do we, for a normal person, what would we set, guys? Yeah, anywhere from 14 to 18. Tidal volume?
450.
So we do about 8 cc's per kilogram on a patient who does not have ARDS, right? So, and this is again, ideal body weight. So based on the patient's height. So we oftentimes think we have these morbidly obese people, like comes 500 pounds, but like 5'6", 500 pounds. They're like, we need to pump in huge volume, 600 cc's. Incorrect. Those patients may get 400 cc's because it's based on height. Your lung size is based on height, not weight. Okay? So 8 cc's per kilogram, usually between 400 and 500. Okay, is what it turns out to be. So if you're in a jam, just do 450. Okay, and the respiratory therapist will help you out. FiO2, we always start at 100 and wean down to sats of anywhere between 94 and 96. Oxygen is a medicine, remember, so even for your hospitalized patients, there's been studies showing that giving patients too much oxygen leads to morbidity and mortality. So we try to get them, we don't like to see the 9900 sats, we like to see more of this, okay? And PEEP is basically, you guys know what PEEP is? Peak end expiratory pressure. You understand the concept? It's like CPAP. When a patient wears a CPAP, it's the same thing. It's just a constant flow of air through the respiration. It helps keep the lungs open and prevent atelectasis, okay? So we usually set that at 8 and keep it at 8, depending on the patient's lung mechanics.
Do you guys get what PEEP really is meaning at the, right, because that's at the alveoli level, correct, you guys? If you don't, just
It's
say,
like,
it's okay, say no, and then we can,
I get it, but if you want to, it's like a fresh it, that'd be great.
it's just constant pressure, like you have a patient's mouth, or dinosaur's mouth, I guess. Not an artist. And it's just constant pressure through the whole, it's going through it's like having a fan in your face, right? It's just constant pressure. It doesn't go down when you're expiring, it doesn't go down when you're inspiring, it's constant, right? So that, when we're on a mechanical ventilator, our lungs, the basilar area of our lungs on a ventilator, when you're on positive pressure, they tend to collapse, okay? So this PEEP, this constant pressure going down, we'll try to keep those open. We also use this in ARDS, which we probably won't talk about. So that's the general concept of PEEP, okay?
and correct me, just so that I can continue to try to teach you the right
Yeah.
way. So the alveoli, as it stays open, has a pressure. That pressure is the PEEP. What it stays, what your body normally can keep it at, your physiologic PEEP. So us is around 5. That's the pressure inside. Is that correct?
Yeah.
Ish.
Yeah, it's
Or is
tough because when we breathe, we're breathing with negative pressure.
Yeah.
So it's kind of, it's a little different, but when you're breathing with positive pressure rather than negative pressure is when you're expanding your chest wall, right? It creates negative pressure, stretching out your lungs, sucking in air. Where positive pressure is we're just pounding air into you, right? So you could say, yeah, physiologic PEEP, like we have PEEP of 5 to 8 that's
Yeah.
already going on to keep these airways, these alveoli open on the bases of the lung. So you get them on, we get the 4 parameters, basic settings, what type of, let's say the patient comes back and the nurse goes, the patient's agitated, what can we do, doctor? They're bucking the vent, they're about to self-extubate. Sedation, right? What are we gonna use? You can use fentanyl and usually,
Or it depends on why they're agitated?
that's right, that's exactly right. So it depends why they're agitated. So you got a big piece of plastic going down your throat, that could be one reason. You just had your belly filleted open for perforated appendicitis. So always think of why. Maybe they're withdrawing from alcohol, maybe, we have patients perfectly awake on a ventilator which don't need sedation. So some people tolerate it very well. But always look for the pain part of it, like Craig said. So this patient, it's a slam dunk. So you can try initially with giving fentanyl, maybe 25, mics, Q, 2 hours, PRN. We like fentanyl because it's short acting, doesn't snow the patient. That's a big, 25 of fentanyl is like 100 of oxycodone. It's very high doses. So people think, oh, only 25, that's pretty high. You could do that. If they're really in pain, a lot of problems, you can start them on a fentanyl drip. So this is pain control. Let's say they're pain, but they're anxious, they're agitated. What do we usually reach for in terms of sedation then? Propofol, yeah. So propofol drip. Go ahead. Somebody say something?
So like this happy guy, like he shows up into the unit, would you start him on a drip or you just do PRNs to start?
Depends how bad he is. Most of the time, I have to say, we'd start him on a propofol drip.
Okay.
And fentanyl PRN.
Alright. So
Okay.
like post-op guy doesn't necessarily need to start a drip.
No,
Okay.
not necessarily. Oftentimes you're going to end up doing it though. Yeah. What's up?
No, I just wanted to say hi.
Oh, hello.
For some reason Tuesday is the beginning of the week. I don't know why you don't get a Monday, but I wanted to thank you guys. And I wanted to, I'll come back later.
Great.
It's all right.
I'm sure I could learn something, but that I know. But all right, no, good.
Okay.
I'll come back.
All right, great, thank you.
What time are you finishing up?
Huh?
I'll come back.
We're probably like 15 minutes.
Okay.
Yeah.
All right, great, thank you.
So propofol. What's the side effects of propofol? Hypotension. Right. What else? What did you say?
Jackson.
Michael Jackson.
Michael Jackson. Yes. Right. Bradycardia too. Okay, so if the patient comes to you in the ICU and says the patient's bradycardic, always check if they're on propofol, right? Always check their med list for, AV nodal blockers such as beta blockers or calcium channel blockers. Other thing that can cause bradycardia is your endotracheal tube banging on your carina. It's too deep. So if you're not finding a reason, get a chest x-ray. Make sure the endotracheal tube's not too deep, okay? But propofol is probably the most common cause, and we'll tolerate sometimes heart rates in the 50s if they're hemodynamically stable, even 40s sometimes. So hypertension, bradycardia are the big problems there. Fentanyl, usually not a huge problem. You can get something called a acute chest tightness. I forgot what the name is, but you can get chest rigidity with fentanyl if you've ever seen it. And you can't ventilate the patient. And you're like, what the heck is going on? And their chest is very tight. Rarely happens with fentanyl. The treatment for that is you paralyze them, actually. What else? So sedation, propofol. Obviously, you get a chest X-ray, right, and an ABG. After anybody's intubated, the chest X-ray, you want to make sure that the ET tube is in the right position, right? Where should the ET tube be in reference to the carina?
6 centimeters above.
Yeah, 2 to 3 centimeters above the carina. So make sure it's not hovering around their neck area. And then an ABG to see if you're ventilating them properly.
Do you get that right away, or when is the when do you get the ABG?
You can honestly do it like 15 to 20 minutes
Okay.
afterwards. People wait an hour, but
Yeah,
you're,
okay.
it should equilibrate in 15 minutes. Yeah. Anything else on vents? I mean, that's kind of the quick and dirty on it, on vents and sepsis, which are the most common things you'll see.
As far as like titrating the event, like let's say this patient, all of a sudden they are like, dipping into the high 80s, so they're not, they're not maintaining their stats where they should
Good.
be. What do you do first?
Good. So let's say the patient's on the vent and the stats suddenly drop to 80%, right? There's a few things. First of all, you make sure the pulse oximetry is on the patient. 90% of the time it's fallen off or it's not a good pleth, right? So check pleth on your pulse oximetry. Number two, you can look at the vent, but what I would recommend is listen to the patient, right? So sometimes you'll hear a big air leak, you'll hear air leaking out of the neck, that means the tube probably migrated up and needs to be readjusted, okay? Respiratory.
You're listening over the trach, or you're listening?
First you listen just to the patient, so you might hear something like, you'll hear air moving through, that means the tube has migrated up and there's air leaking past the tube, out, right? And then you listen to the patient. It's tough, I mean, in the ICU, listening to patients is to hear decreased breath sounds from one side to other is like really difficult. But if you really hear no air, you may think it's a pneumothorax, right? So listen for basically migrated tube, pneumothorax, which is decreased breath sounds, but you'll always get a chest x-ray, and wheezing, right? Wheezing or crackles. If they're diffusely wheezing, you'll probably see the peak inspiratory pressures on your vent go up. The peak pressures, as the respiratory call it. Oh, your peak pressures are up on the vent. That probably means the tube's obstructed or you're wheezing. Okay. If you have crackles, you may be in CHF or ARDS. But the main things you'll do is, I mean, if the patient is really desatting, you get a stat portable chest X-ray, right? Order it while you're examining the patient. Listen to the patient. If the patient is agitated, it's probably vent desynchrony. They're not synchronous with the vent, and you need to sedate them more. Okay? That we see a lot too. Their stats are like 88, 87. They're like guppy breathing. You need to sedate them more. What you do on the vent in the meantime, the nurses or respiratory will already do this. They'll turn them up to 100% FiO2 right away. So that's the first thing to do while you're figuring things out, right? Let's oxygenate the patient. Then you look, is there a leak? Is there breath sounds that can indicate if they're having COPD exacerbation on the vent? Are they in pulmonary edema? Or do they have breath sounds that are decreased, waiting for the chest x-ray to show a pneumothorax? Or their ET tube migrated into their right mainstem bronchus. Well, the x-ray will show that too, right? And you're only ventilating the right side, not the left. And then, is the patient sedated enough? Okay. Very rarely, which is scary, this happened to me maybe a couple times, where the ET tube itself is obstructed, and the way you know that is if you try to put the suction catheter down, it just won't go. Sometimes that means the tube has migrated down too much, so pulling up a little bit. If that's not the case, just call stat anesthesia to re-intubate, okay? And the respiratory will let you know, like, I can't get this down, okay? That happened to me like 3 or 4 weeks ago in a trach, and the trach had migrated out of it had a false passage. Anything else?
Is desynchrony the same as like breathing over the vent?
No.
It's not?
Desynchronous is, the patient looks uncomfortable,
Okay.
right? Breathing over the vent means the patient is actually breathing on their own. And so you set the respiratory rate to 16 on the vent, but the patient is breathing at about 18 or 20. And this goes more into a little more advanced vent talk, but when you set, can I go back a page or no?
Yeah.
So when we set these, right, respiratory rate, let's say we set at 16, that means the patient is guaranteed 16 breaths on the vent at this tidal volume. If a patient tries to breathe on their own, they'll automatically get 500. The vent will give it to them right then. So you can breathe above the vent. So patients can breathe comfortably above the vent, or they can be desynchronous, meaning they're trying to breathe and the vent's trying to, and you'll see they'll have belly desynchrony. You know, the ventilator's trying to push in oxygen and they're trying to exhale. So they'll look uncomfortable. You'll know that. And the nurse will tell you too, they're desynchronous or respiratory will tell you that. And in that case, you can give them two of Ativan or something just to settle the dust, really sedate them. 2 of Ativan, 1 of Dilaudid, just get them sedated. Okay? People are, oh my God, they're gonna get hypotensive. We deal with hypotension all the time, so you have to put them on a little pressor during that. That's not a big deal. Okay? Anything else? Any hot topics in
So with COVID,
Yeah.
I don't know, maybe you can answer a few questions on
Yeah.
on that. What's changed since we were working down there?
So with COVID, you guys were down there when this changed. In most patients, when they're on a lot of oxygen on BiPAP or Vapotherm, you guys know what Vapotherm is? Vapotherm is high. Vapotherm is the brand name. So with nasal cannula, you can give up to 5 to 10 liters of oxygen, okay? Vapotherm is high flow oxygen. You can go up to 40 to 60 liters of oxygen on this. You set an FiO2 tube, the amount of oxygen. So FiO2 in liters flow, okay? On Vapotherm. So it's a device, it's a nasal cannula, and it's 40 to 60 liters. It's humidified. They're a little longer wider prongs so that it's more comfortable for the patient. Some patients do find it uncomfortable because it's such a high liter flow. So you can give a lot more oxygen with this Vapotherm, right? It's called high flow oxygen. So we were treating these patients with COVID who were very hypoxic with Vapotherm and BiPAP. And usually when we treat patients like this, if they're somewhat tachypnic, even with this, they look somewhat uncomfortable, we'd say, they're failing this, let's intubate them, right? At this point in COVID, we see that mechanical ventilation really harms the lungs in patients with COVID, so it's kind of like a last ditch effort in putting them on the ventilator. So I taught when was the last COVID patient that was really bad, I was tolerating SATs 84% for a day or two before we intubated them, because we knew that was the last step, and I ended up sending him out on ECMO actually. So one thing is our management of respiratory failure. We wait a lot longer and have the patients a lot more uncomfortable on Vapotherm or BiPAP when we're treating them.
So it's basically the opposite philosophy, wasn't it?
Completely opposite when we started in the U.S. Yeah, we were told to intubate them as soon as possible because they crash fast. So the paradigm just completely shifted, right? So treatment of it, basically, obviously supportive care, good critical care, remdesivir. Can't give it to moderate renal failure patients, okay? Remdesivir. Decadron, which is a steroid you guys know of. I think this has helped a lot. So Decadron we give to patients who are on oxygen in the hospital.
So anybody on oxygen is on Decadron?
COVID, yes. So the study showed basically patients benefited from steroids with COVID. Patients who weren't on oxygen actually did a little worse. Patients on oxygen, they had the mortality benefit.
How much and how long?
It's 6 daily times 10 days.
6 daily? Orally?
IV. Okay.
So if for your typical COPD, we see, you already see solid methanol, 121.
Yeah.
You're not using that at all?
We're not. I mean, you could do the equivalent. It should work the same. I can't do the calculation in my head. The Decadron to solumedrol change. You could use Decadron in COPD too.
The Decadron has a longer half-life, right?
Yes, lot longer half.
Very long.
Correct.
Oh, yes,
30
yeah.
I forgot what it was.
Yeah,
36
it's
hours
it's a
or
very
something.
long half-life. It's like 36 hours, you're right.
Plasma out?
Huh?
Plasma no more?
So we got remdesivir, Decadron, plasma we still use. The data on plasma is not as good as it used to be, but we still use it. So medication wise, and then we oftentimes will still put patients on conventional antibiotics just to treat for bacterial infection on top of their COVID. So antiviral, steroid, plasma,
Okay.
and antibiotics. I feel like I'm missing something.
Is the steroid for the?
Does the medicine team know about this?
Is the steroid for the prevention? of
Okay, because they're the primary team taking care
Yes,
of making the
correct.
care.
Yes, that's the other thing. We use something called the IL-6 inhibitor
Yeah, yeah.
called teclistamab.
Oh, yeah.
So those patients who have this cytokine storm, as Craig is talking about, we're thinking Decadron probably helps that. So it's not the actual viral infection, it's our body's response to that infection that causes these patients to get this sick. So Decadron helps quell that. And this IL-6 inhibitor, which is an inflammatory cytokine, we use teclistamab if their CRP is greater than 15.
And who gets remdesivir?
Basically, anybody should get remdesivir. I know our ID guys are not using it as much on the floors, but we really should be giving it to anybody who is on
Most
oxygen.
people on A3 on oxygen should be getting
Not a lot of them are, but they should be.
Okay, when was his oath, was the last?
Should be getting what?
Remdesivir.
And then who gets plasma?
Anybody. Like, same thing. I would say for these three
And
things,
that was on 2 liters?
anybody who's hospitalized is probably deserving of it. And right now, we're still, because of infectious disease, we're probably only using these in the ICU outside of Decadron. Most A3 patients are on Decadron because they're on oxygen.
Are we limited as far as how much we have?
Remdesivir, we may be limited. Plasma, not really.
Yeah, I think
We should be
I'm
giving
gonna
plasma to
go
everybody.
And all those three, or it's early in the treatment, you're not waiting for
Yes,
them to tank before you start.
correct. Correct.
Alright, so let's cut to the chase here. What's-
Last thing, so IL-6 and number 5 is self-proning. Have you heard of that? So these are when the patients turn, right? So they can do that on A3 by themselves. That helps oxygenation when they're laying on their belly.
Oh, yeah, they got them.
So let's cut to the chase here. How bad do things have to get before you guys drag us back?
Okay, yeah.
I don't know. I feel like Decadron is really helping, you know? So a lot of the patients now with COVID are not in the ICU, they're on the floors, you know? Where previously, you know, our ICU was full, we were using the PCU when, you know.
So.
So-
Clear.
Yeah, exactly. COVID is over. Spread the news. Fake news.
Oh,